Hey everyone. We're going to go ahead and get started into our content for this week. So, week 8. We are now officially going into the PEDS portion of our class. So, if you enjoy children, hopefully you'll really like this part of the class. Um, so, I'm going to go ahead and go over some of the objectives of our stuff that we're talking about today. So some of the things that we're going to get into would be things specific to communication. So we're going to describe the process of normal communication. We're going to look at patterns of family communication. We're going to describe family dynamics, different family theories, family function roles. We're also going to look at family structures and the approach to communication within the structure. We're going to identify age-specific approaches for communicating with parents, families, toddlers, school-age children, and adolescents. And then we're going to explain various influences in communication, like body language, tone, pitch, and environment. We're going to describe strategies for incorporating communication into assessment. And we're going to describe communication with families during periods of emergency care. And we're going to identify the role of family-centered care in caring for the hospitalized child. So lots of stuff. All right, let me see. Here we go. So this is our chapter 3 that we're starting with. I already went over all of those objectives with you, so we're going to start right here at the introduction. So the manner of communication used by families provides information about the family style and structure and function of the family relationships. Functional communication influences the decision-making process and is based on mutual trust. Dysfunctional communication inhibits nurturing and results in a decrease in self-esteem and self-worth and in communication partners. Communication is influenced by culture, so nurses must have a cultural awareness to facilitate effective communication with their clients. On here, it talks about the principles, process, and patterns of family communication. So some of those things are, we want our communication to be clear and direct. This means that we send a clear message directed to the appropriate family member. If we're sending a clear and indirect message, that means it's a clear message directed to the wrong family member. If we are sending a message that is masked and direct, this is an unclear message delivered to the appropriate family member. And then the last type is masked and indirect. This is an unclear message that's not directed to a specific family member. So some parts of the communication process would be verbal and nonverbal, right? So when we talk verbally, it's spoken words or written words. That would be all encompassed in verbal. In nonverbal communication, that would be things like body language, gestures, paralanguage, which is pitch, volume, and pacing. With health and communication, children learn health habits from their families. So it's also influenced by peers, by the media, and by insurance status. So like what I mean by that by insurance status, if you don't have insurance, then you technically, well, a lot of times people will just stay away from hospital care or any type of medical care because they can't afford it. So they just kind of suck it up and deal with it at home. Okay, so barriers to effective communication. A couple of things that I saw in the book where, you can have a physical abnormality. So if you have cleft lip or cleft palate, that would be a physical problem that could cause you to not communicate well. Physiologic alterations like hearing or vision impairment. So yeah, if I have trouble hearing, I'm not necessarily going to be able to communicate the greatest. Cognitive barriers can affect perceptions, expression, and concrete or abstract thinking. Avoidance of distancing language, for instance, like acting out, denial, projection, rationalization, or trivializing. Geez, I can't say it. Okay, so when we talk about family, A family consists of two or more members who interact and are dependent on one another socially, financially, and emotionally. There's all different types of families out there, right? So we have single parent families, cohabiting families, remarried parents, two parent families, you name it. So all these different types of families have functions to them, right? So we have things like, um, let me just kind of continue to explain a little bit about the family types, right? So we've got, hey, what is my family of origin? So that means families that raise their children. So, like you have a mom and a dad that raises you. That's your family of origin. Family of choice. This is family formed through marriage or cohabitation. Then there's nuclear family. This is a male and a female parents and their children living separately from grandparents. Then there's an extended family. So 3 or more generations of family members living in the same house. And there's more and more, but those are a few of the examples that I wrote down. When you look at a family, everyone has certain roles and tasks that they have to do, different functions. So family members interact and participate in activities with one another. A single adult might function as a disciplinarian. When you look at the birth order of children, sometimes that influences how communication is done. Personality differences, relationships, and careers also influence that. So typically, looking at that birth order, if you look at the firstborn child, they typically are a perfectionist and they are more direct with their communication. The middle child is typically one that is a conflict avoider and a mediator, and sometimes they show avoidance communication patterns. And then the youngest child tends to have self-centered communication patterns. So there are a lot of stressors out there to different families. So things like loss of income, poverty, homelessness, lack of support systems, cultural and religious constraints. Those would be some things that could be a stress on a family. Also, reaction to a child's illness. So disbelief, frustration, worry, anger, denial, anxiety, depression, fear, and guilt. So that's a huge one there. I know with my husband's sister that has muscular dystrophy, I think this was a big deal when she was diagnosed back when she was 12. It changed the whole family dynamic after that. And so his parents just never were the same after that. They totally, I don't know, they just don't act the same as they used to. With nursing interventions. So you want to communicate openly with parents. You want to encourage the parents to care for their child while the child's in the hospital because the more they're involved, the better. That usually makes everyone feel better that way, the kid and the parent. Develop a trusting relationship with the parents and then begin to do discharge instructions as soon as the child is admitted. That's kind of important. I know it seems like it's too soon or something, but it really is very helpful to plan ahead. And then also encourage siblings to visit. So if you have a sick child, it affects everyone. It affects the other kids in the family too. So it helps if they can visit. All right, so this starts to get into a little bit about communication theory. So this slide talks about what's a healthy family compared to a non-healthy family. So a healthy family is going to give clear, congruent, consistent verbal and nonverbal cues. They're going to help their children move forward in the decision-making process. They're going to foster the child's attainment of autonomy through support and guidance. And they're going to encourage interactions and consistently interact in a positive manner. They are going to derive pleasure, companionship, kinship, and love from one another. So that's a healthy family. The unhealthy family, on the other hand, they give inconsistent, non-congruent verbal and nonverbal messages. They humiliate, intimidate, or control communication. They do not promote decision making through communication. They neglect interactions because of lack of knowledge, time, or interest in the child, as well as other barriers. All right, so the book starts to get into a little bit about family theories. So they mention quite a few different ones. So I'm just going to kind of give you a blurb about each one. So, family systems theory. This theory says that changes that occur in aspects of one family member's life affect the entire family. Families usually strive to maintain balance during a crisis, and this theory focuses on the family as an emotional unit, and they talk about triangulation. So, like you have one parent, the other parent, and the child. So, just it kind of makes a child or a triangle. Um, then there is the resiliency model of family stress, adjustment, and adaptation. This assesses a family's ability to adjust during times of stress and crisis, function effectively, and adapt to stressful hospitalizations and disease processes. Because this is a big deal. When someone is sick and they get it put in the hospital, it affects everything. We just had friends of ours who one of their kids, trying to think how many weeks ago this was. I think it was last month this happened. One of their kids started to get sick, and they thought it was just like an episode of the flu or something. They were throwing up and whatnot. And this is a pretty young kid, and so the next day, I guess he was still having trouble, and then they were having a hard time like waking him up. Like he couldn't stay awake for very long. So they're like, "Oh, we need to take him to the doctor." So they took him in, and here this kid had a cyst on his brain. So he ended up having to have brain surgery. So huge deal, right? You can imagine none of the people in that family were expecting that. And it's such a serious surgery. So everyone was freaked out and very scared. And this is a big family. It's not just the one kid that they have. They have, I think, they have five kids. So everyone was affected. So this kid was in the hospital for a while. The parents had to stay with them, and then, the older siblings had to care for the younger ones at home, and it was just very stressful for them. So if you were the nurse and you had that family in the hospital, you could technically use this theory to try and see, how they were dealing with everything. Okay, Murray Bowen and family system theory. So the family is a unit in which members are emotionally connected and interdependent. A change in one member's role or functioning will impact the functioning of other roles of other members. So that's what that one's about. Then the Virginia satire and family therapy. The goal of family therapy is to deal with one family's pain. Wait a minute. The goal of family therapy is to deal with family pain that is manifested in one family member but affects other family members in one way or another. So, for instance, say you have a adolescent child who, I don't know, they're going through something bad, like they have a really bad depression where they try and commit suicide or something. So if you went to family therapy, if you did this theory, it's all about the whole family, because that event, that one thing that happened, even though it's to that one person, it still affected everyone else. And so everyone needs to kind of talk and figure things out together. Okay, Duval and family development theory. So with this one, the oldest child in the family marks the transition of family into the next stage. The family is a small, semi-closed system that interacts with a larger social system. A family's life cycle stages are based on changes in the structure, function, and roles within the unit. Understanding their current stage of development can assist the nursing staff in identifying areas where education and anticipatory guidance may be needed. So when you look at this theory in the chapter, it talks about the different stages, and they go through beginning family, childbearing stage, preschool stage, school age stage, adolescent stage, and launching. So that's kind of how you're looking at that one. All right, and then it goes on to a little bit more theories here. So obviously, when we end up having our next test, you're going to want to focus on a lot of these theories to make sure you have down what's what. So Newman, Betty Newman, she is famous for systems theory. So with this theory, it says a client is an open system that responds to stressors in the environment. Nursing interventions are related to three primary areas of prevention. So you have your primary, your secondary, and your tertiary interventions. So that's all Betty Newman's systems theory. Then you have family focused care. So a child receives the best quality of care when a healthcare provider works with the parents and family. If you leave everyone out of the loop, you're not helping anyone by doing that. You always, make things better when you involve the family. Structural functional theory. So family is a social institution that is essential for the continuation of a strong society. Each family must successfully perform four main functions to be considered functional. The functions include sex, procreation, economic function, and socialization. Then this talks about King's theory of goal attainment. In this theory, they say family is an interpersonal social system. The nurse, the child, and family communicate information, they set goals together, they apply interventions to achieve those goals. And then the last one is Callista Roy. She did this adaptation model. This model says God and humans have a relationship with the environment, and humans are an adaptive system that strives to maintain balance with either healthy or unhealthy adaptations. Okay, so then this says, which of the following describes Duvall's family development theory? And there's stuff on both slides here. So A says the family is a target that should be assessed and to which nursing interventions should be applied. B says a child receives the best quality care when healthcare providers work with the parents and family. C says the family's life cycle stages are based on changes in the structure, function, and roles within the unit. And D says the family is a unit in which members are emotionally connected and interdependent. So the answer is C. So that Duvall's theory states that families' life cycle stages are based on changes in structure, function, and roles within the unit. Okay, the next part of this talks about family assessment. So when we do a family assessment, we are going to look at family size and shape. So we're going to see what is the structure of this family? What's their socioeconomic status like? What kind of resources do they have? What is their physical and emotional health? And are there any influential factors? Average family size has decreased compared with a generation ago. So used to be we'd have bigger families than we do now. Now it's a little bit smaller. Then you're going to look at parenting styles. And this is kind of an important concept, so make sure you focus on this a little bit. So there are three, I guess you could say three different parenting styles. We've got authoritarian, which is kind of like, I'm the dictator, that kind of parent. So you have absolute rules, strict expectations. Children have little decision-making power in this type of parenting style. Then you have the parent who is a permissive parent. This is where children control their environment and make their own decisions. Few rules to follow. And then the third one is a combination of the two. So it's called authoritative or democratic. So this person has firm rules that allow some freedom to their children. Children are taught the correlation between actions and consequences of those actions. So those are the parenting styles. And then when we talk about roles and relationships, when you're looking at a family assessment, you say, hey, how are tasks delegated in the household? How is good and bad work rewarded or punished? Look at their clothing and personal hygiene. Is personal hygiene congruent with the caregiver and the child? And then look at the condition of the home. Who makes the decisions? How are problems solved? And then this talks about some tools that you can use for assessment of the family. So the first thing they mention is the genogram. And remember, we've talked about a genogram before, just not too long ago in our community class. So remember, a genogram is just a pictorial representation of the family unit, and it diagrams health concerns and behavioral patterns. So like, for instance, if you did a genogram about everyone in the family who had depression or something, and you made a certain kind of notation about that on the genogram, like maybe it was a star that would show that that person had depression. You could see how it's passed down from generation to generation. You could get, some information from that. And then there's a kinetic family drawing. So this is where a child draws a picture of the family unit. This is the child's view of the family and can reflect the family's health and area of distress. Okay, guys, the structural family assessment. This is something that where you would say who lives in the home, what is the family's composition, what are the occupation and educational levels of the family members. Then you could also do a functional family assessment. This is one where you would ask who has the power to make the decisions in the family, what characterizes family interactions and their roles, what communication methods are used, and how are they successful. And then there's also something called a family APGAR. This is a 5-item questionnaire. And you know how we talk about APGAR, with our maternal newborn stuff. So, when a baby comes out, you give an APGAR score to it. So with this APGAR, for the family APGAR, A stands for adaptation. So this is the ability to use resources for problem solving in a crisis. P is for partnership. This is the ability to share responsibilities and nurturing roles in a crisis. G is for growth, the ability to achieve physical or emotional growth. A is for affection, the ability to demonstrate love and attention to family members. And R is resolve, the ability to devote time to other family members in the nurturing process. All right, so then this gets into a little bit about communicating with children. So when you try to communicate with an infant, it's difficult because infants can't talk to you or anything. But some things to know about infants. If you learn the infant's routines, like their feeding and their changing and sleeping routines, sometimes that's helpful in communicating with them. Use a gentle touch when handling the infant to provide a sense of security and comfort. Use a sing-song approach to communication because this can quickly gain the infant's attention. Infants are often quiet, observing the environment around them. Infants coo when they are content and happy. When we communicate with toddlers and preschoolers, that's a little bit different. So we want to use simple terminology when we try to talk to them about something, because young children are not able to understand certain concepts. So when appropriate, offer the child choices so that control can be maintained. You can say, hey, do you want water or juice after you swallow this medicine? Then you want to prepare the child just before the procedure, not days in advance. So kids this age, they will get freaked out about a procedure. So you don't want to do it 2 or 3 days before. you do it just before the procedure. Then when we talk about school-age children, you want to explain the why and the how in simple, nondescript, and non-fearful terms. You want to allow the child to participate in procedures safely, such as taking off an adhesive bandage or depressing a blood pressure cuff. And then when we communicate with adolescents, we want to use open-ended questions, explain the limits of confidentiality, and then do not confuse the adolescent's mature body with emotional maturity, because that's two different things. Okay, here's another question. Which of the following is an appropriate method for communication with infants? So the answer is use music and sounds to assist in soothing the patient, B. Okay, this is talking about communicating with the altered family unit. So substance abuse is a bad problem that you see a lot in families. So this can negatively affect that family. The abuser often is enabled because of denial, pride, or embarrassment. The family unit is codependent, and there may be inability to communicate with outsiders. They might be like secret keepers. And then there's something called coercive family processes. This is where punishment is used inconsistently, rewards are coerced, the child's behavior is ignored by the family. Physical, emotional, or sexual abuse. With this type of situation, secrets are kept within a family, preventing resolution. Usually one member of the family is singled out for abuse, and the non-abuser parent may ignore or cover up the abuse. Also, there's chronic physical or mental illness. A lot of times, if someone has mental illness in the family, that's very stressful for them. The other family members usually have to take care of it, and it's a big deal. With hospitalization, if a family member gets hospitalized, it often triggers a crisis. So nurses may need to help coordinating resources for them, to be able to function appropriately. With death of a family member, developmental levels of family members affect their responses to death. So in other words, if I'm a toddler, I'm going to respond differently than I am if I'm an adolescent to this person's death. Responses to death change in children over time as their understanding of death becomes more concrete. So as you can see in this chapter, we talked about, how we communicate with families, what a family is, some of those communication theories. We talked about some of the different horrible things that you could see that might happen to the family unit. And then just how to do a family assessment in this chapter. So that was chapter 3. So we'll go ahead and pull up chapter 4 here. This chapter all has to do with cultural stuff. So almost in every class we have in the nursing program, we talk about culture. So it's very important to get these concepts down, because you have it in every class. Okay, so some of the objectives for this chapter. We want to identify individual cultural bias. We want to discuss Leninger's theory and how it can be used to plan patient care. We want to identify effective cross-cultural communication, body language, nurse-patient relationships, and multidisciplinary relationships between the caregiver, family, and pediatric patient. We want to identify strategies for overcoming language barriers and describe the importance of doing so. Other things we're going to talk about, we want to identify and describe the characteristics that are determined by culture. We want to describe the components involved in a cultural assessment. How we want to talk about how spiritual beliefs influence the care of the child and the family, and then identify environmental and societal considerations when caring for the pediatric patient and family. Okay, so the first thing this gets into, it talks about cultural competence. And remember, we've talked about this in all kinds of other classes before. So what this means is culturally competent care must consider the client, the culture, the spiritual beliefs, the values, the traditions, the behaviors, and environment, and how these factors impact care to provide optimal outcomes. So culture serves as a template for evaluating the patient and family's psychosocial needs. When these needs are met, the client is better able to participate in care and focus attention on individualized health education. And what do we mean by cultural bias? So this can occur when the nurse places his or her own values before the values of a different culture. Nurses must examine their own belief system and know that it may influence the care that is provided and prevent bias from occurring. So if you examine your own beliefs, you can kind of prevent that from happening. Okay, so some environmental considerations. A person's home environment has a substantial impact on his or her outcomes. It influences how care is delivered, the types of food available, how medication is stored, whether the patient has privacy at home, you name it. So things to assess with the environment would be, what is this person's socioeconomic status? Do they have a safe area outside to play? Do they have this, access to safe drinking water? Are they exposed to lead-based paint? Do they have enough police patrol in their neighborhood? So all of those things kind of, affect how they're going to do. When we talk about health disparities, these include social and economic status along with it. So things that can make you have a health disparity would be your race or your religion, your socioeconomic status, your sex, your age, your mental health, your cognitive, sensory, or physical disability, your sexual orientation or gender identity, your geographical location. And I thought this was kind of interesting in the book. It said, health equity is not necessarily equality. Equality is giving everyone the same. Equity is giving everyone what they need to be successful. So in your book, they talk about Healthy People 2020, and they have this whole chart that breaks down the projected ethnicity that's going to happen, over the next year or so. So they say in 2020, less than half of children living in the US will be classified as white or non-Hispanic white. So racial changes bring health disparities. So that's something that we're going to have to consider. So when you look at this, you see, Hispanics make up 26%, Black non-Hispanics would be 14%, Asian non-Hispanics would be 5%, and then it kind of goes on from there. So we're going to have a big variety of people who may be more at risk for health disparities. Okay, so when we talk about cross-cultural communication, we want to communicate in a language that's best understood by the person receiving the information. We want to use a certified interpreter when it's needed. We want to speak in a tone appropriate for the situation. And we want to provide undivided attention to the patient and caregiver. Be aware that silence, eye contact, personal space can mean different things in different cultures. So we also have to be aware of our body language and touch awareness. So when you're caring for a person of another culture, be aware of the types of body language that and touch that's acceptable to that individual culture. Consider elements that may be interpreted differently by those of another culture, such as eye contact. Sometimes direct or indirect eye contact is not something that they want. Nodding of the head, sometimes that can be taken differently. Touching the top of the head, shaking hands, particularly with a member of the opposite sex, can be taken the wrong way. And then hand-arm gestures also can be taken differently. So the nurse-patient relationship is really important to build right off the bat. So you want your patient to realize that whatever they tell you is going to be kept confidential, that the relationship is developed on mutual respect, patients are treated as unique individuals, and relationships are kept within the boundaries of the care setting. Um, and then when we talk about language barriers, we want to, it's difficult when you have someone who doesn't speak your language. It just is. But you want to avoid using charades to communicate. Just wait for the interpreter because you're going to have a better time. Pictures can be used to help communicate when an interpreter is not available. Family members can be used as interpreters, but take caution because this interpretation is only as accurate as the message that's being conveyed. That means that, yeah, maybe I can have the son or daughter be the interpreter, but you don't speak that language, so you're not really sure if they're saying everything that you're asking them to say. They could be saying something else. An interpreter is free and should always be used when teaching is done or if a consent is needed. Okay, so some characteristics and behaviors are determined by culture. So again, personal space is a big deal. So personal space is expected between communicators and you should respect that space that's provided. With eye contact, you want to try to know the etiquette of eye contact among different cultures. Provide eye contact if you're unsure whether it's appropriate or not. Just go ahead and do it. With diet, children will more likely eat foods that they have often had before. Encourage parents to eat with their kids to maintain normalcy, especially when they're in the hospital. Um, for time, perception of time may be different among different cultures. Maybe this particular culture needs time set aside for prayer. With touch and communication together can be offensive to patients and caregivers, so you have to be careful with that. And then family use of alternative medicines. So a family leader may be the one that dictates how to treat this person's symptoms. Um, a lot of people use different herbs, just because of their belief systems, so they use herbs. Herbs can cause drug interactions, so you have to be super careful with that. And then treatments should be accepted if they will not harm the patient. So even if you think whatever they're doing is totally off the wall, if it's not going to harm the patient, then let them do it. Okay, which one of the following best practices is related to effective communication? So our answer is A, know who is responsible for making health decisions for the patient. Okay, when we talk about cultural assessments, these are a mechanism through which the nurse gathers subjective data to identify beliefs and values associated with the patient's culture. This assures the patient that the care provider is interested in the patient's values, and it allows the care provider to individualize care and incorporate cultural beliefs and values. The cultural assessment should evaluate religious beliefs, client and family perceptions of the current health status, food preferences, and typical daily schedule. Okay, so they're in the chapter, they talk about Geiger and David Heiser's transcultural assessment model. So in this model, they look at these different areas: communication, space, biological variation, time, control, and social organizations. So with communication, this is how thoughts and feelings are expressed. So they look at that. They look at personal space between people communicating. They look at biologic variations. So, hey, is this person the appropriate weight? Are they developed fully? With time, they look at both perception of time in general and when daily events should occur. And then with control, they are looking for the degree to which individuals feel they can influence or control their environment or experiences. And then with social organizations, what is the patient or family part of? So are they, part of a religious affiliation? Do they do some type of social group? So you're looking at all of those types of things. All right, and another part of cultural assessment is looking at spirituality. So a person's belief in a greater being that affects his or her daily and world events, that's spirituality. So their belief encompasses the concepts of where and how humanity began, and also views of the afterlife. So, and then the next thing this is talking about is that we need to respect this person's religion. So nurses should become familiar with the religious beliefs of the patient and the caregiver. Information about religious affiliation can be obtained from either the patient, the caregiver, books, or caregiver suggested internet sites. The patient and caregiver beliefs should be respected regardless of the beliefs of the care provider. All right, and then the last part of this talks about this FICA assessment tool. So this tool allows patients and families to describe their spiritual beliefs and concerns on their own, in their own words, and to participate in the creation of their plan of care. The nurse will also better understand the patient's viewpoint when providing care. So with this assessment, there is a box on page 64 in your book, box 4-1, that goes into more detail about this FICA assessment. But the different areas on this assessment tool that they look at are faith and belief, which you would look at things like, do you consider yourself spiritual or religious? Do you have spiritual beliefs that help you cope with stress? What gives your life meaning? Those would be things you would ask in that. Under importance, I. So what importance does your faith or belief have in your life? Have your beliefs influenced how you take care of yourself in this illness? What role do your beliefs play in regarding your health? With the community, with C, are you part of a spiritual or religious community? Is this a support to you? If so, how? Communities such as churches, temples, and mosques or group like-minded friends can serve as a strong support system for some patients. And then the A, address and care. How would you like me, your healthcare provider, to address these issues in your healthcare? As with any other part of the patient interview, these spiritual histories should be patient-centered. So the tool is meant to create an environment of trust by indicating to the patient that the physician or healthcare professional is open to listening to the patient about his or her spiritual issues. So that's something that's available to use, as part of the cultural assessment. All right, and then this last thing, a cultural assessment should evaluate which of the following areas, and it's going to be D, all of the above. We want to know their religious beliefs, their food preferences, their typical daily schedule. So again, in this chapter, we talked about how we as nurses can give culturally competent care. We talked about how we should do cross-cultural communication, and then how we can, look at the cultural patient a little bit closer with a cultural assessment. Okay, guys, so that was our topics for this week. Not a whole lot, so hopefully it doesn't blow your mind too much. I want you guys to make sure you listen to this recording and take notes on this stuff in your chapter. If you were ready ahead of time before we go over this stuff, it's not going to be as bad to learn. So try to stay ahead of that and look at the topics before, and then take notes before we have class. Hopefully you guys did well on your test, and I will see you soon. Have a good week off.